Hello and welcome to our channel, where we discuss common medical topics from a practical point of view. Today, we will be discussing hypertension, how to initiate treatment. Please review our previous videos, which clarify how to establish the diagnosis of hypertension and how to take appropriate blood pressure reading. So let's start with a hypothetical patient. We'll call him Tom. So Tom comes to our clinic and we evaluate him for hypertension, and his blood pressure comes out to be 135/85 millimeters of mercury. Now it is established that Tom has hypertension, and this is classified as stage 1 hypertension as per the AHA classification system. Before we begin treatment, we have to ask a few questions. Does Tom have any one of the following? Established cardiovascular disease like coronary artery disease, stroke, TIA, or peripheral arterial disease? Does Tom have chronic kidney disease or an underlying renal transplant? Does Tom have diabetes? Does he have heart failure? Or is his estimated 10-year risk using the prevent calculator more than or equal to 7.5%? If any of these indications is present, then Tom needs pharmacological treatment. If none of these indications is present, then Tom needs lifestyle advice and close monitoring. So let's say after assessment, unfortunately, Tom requires pharmacological treatment. How do we decide which drug to initiate and how do we titrate those drugs? This is what we'll be discussing in the coming slides. So while initiating a particular agent, we will always consider if there's an underlying indication for a particular agent. This we'll be discussing in the coming slides, how to select a particular pharmacological drug for an underlying indication. So at stage 1 hypertension, usually a single pill or single agent treatment regimen is preferred. So some of the common agents include ACE inhibitors, angiotensin receptor blocker, calcium channel blockers, and thiazide-like diuretics. So we initiate a particular agent and follow the patient up for 2 to 4 weeks. So let us now further discuss how we can select a particular agent for the treatment of hypertension. Like we have already stated that for stage 1 hypertension, it is recommended to start with a single drug regimen. Sometimes there can be a particular indication for selecting a specific antihypertensive agent. For example, if Tom has heart failure, then ACE inhibitor, ARB, beta blocker, diuretic, or aldosterone antagonists are recommended. Post-MI, ACE inhibitor, ARB, beta blockers, aldosterone antagonists again. For proteinuric CKD, ACE inhibitors and ARBs prevent progression to end-stage renal disease. For patients with angina, beta blocker and calcium channel blocker. For patients with atrial fibrillation, beta blockers and non-dihydropyridine calcium channel blockers. For patients with underlying hypokalemia, aldosterone antagonist will be helpful. Sometimes the pharmacological agent or pharmacological antihypertensive agent that we select can be determined by other comorbid conditions. For example, if the patient has BPH, then alpha blocker will have beneficial effect on both hypertension and the BPH. Similarly, beta blocker for hyperthyroidism. If patient has underlying migraine, beta blocker and calcium channel blockers, they'll have a beneficial effect both on the hypertension and the underlying comorbid condition. For osteoporosis, thiazide diuretic can be helpful. For patients with Raynaud phenomenon, dihydropyridine type calcium channel blockers will help control the symptoms. Some other factors that can determine the selection of the antihypertensive agents are contraindications. So let's say Tom has history of angioedema, then ACE inhibitors are contraindicated. If he has bronchospastic lung diseases, then non-selective beta blockers should be avoided. Alpha-methyl dopa should be avoided in patients with liver disease. Patients who can become pregnant or are pregnant should avoid ACE inhibitors, ARBs, and renin inhibitors as they're teratogenic. Patient with underlying heart block should avoid beta blocker and non-dihydropyridine type calcium channel blocker. Then there can be some underlying comorbids which preclude selection of a particular agent. For example, people with hypertension and depression, we should avoid beta blockers and centrally acting alpha 2 agonists. For patients with hyperkalemia, we have to avoid ACE inhibitors, ARBs, aldosterone, basically drugs acting on the renin-angiotensin-aldosterone system. For patients with hyponatremia, avoid thiazide. For patients with gout, we have to avoid thiazide and loop diuretics. So this slide actually explains how a particular agent can be selected. Now let's say we have started a particular pharmacological agent. Let's discuss the follow-up. So usually we call the patient back 2 to 4 weeks after initiating treatment. Keep in mind that the maximum effect of the antihypertensive may take up to 4 weeks. So avoid escalating or intensification of treatment during this period. You have to monitor electrolytes, creatinine, after starting drugs like ACE inhibitors, ARBs, and diuretics. In some patients, you can even consider earlier follow-up, especially for monitoring of side effects. Like patients in chronic kidney disease are highly prone to electrolyte abnormalities after initiating ACE inhibitors and ARBs. So at follow-up, you will again check the appropriate blood pressure, whether it is at the target goal or not. If the target goal is achieved, then you can call the patient for follow-up every 3 to 6 months. If goal is not achieved, then treatment intensification and again follow-up every 2 to 4 weeks. Now let's consider another hypothetical patient. Let's call him Jerry. Jerry comes to our clinic. His blood pressure is also elevated. The blood pressure reading is 160 over 95 millimeters of mercury. So Jerry has stage 2 hypertension as per the AHA classification system. Now, patients with stage 2, unlike stage 1 hypertension, need pharmacological treatment, regardless of underlying comorbids. We will be discussing how to select a particular agent in the coming slides. So let's see what treatment options we can offer Jerry at this stage. So for stage 2 hypertension, it is recommended to start treatment with low to moderate dose of 2 separate agents. It is also preferred that these agents be present in single pill combination as it improves adherence and leads to a better control of blood pressure. Treatment with free equivalents is also reasonable if cost, availability, or patient preference is an issue. So drug selection. Again, for drug selection, we have to consider if a particular underlying comorbid condition or indication exists for selection of a particular class of antihypertensives. Combinations usually from 3 main classes like ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics are considered. Here are some of the preferred drug combination. ACE inhibitor, ARB, and dihydropyridine type calcium channel blocker. ACE inhibitor, ARB, and thiazide are reasonable alternatives. We can also use calcium channel blocker along with thiazide. However, there's no single pill formulation for this combination. Some combinations should be avoided due to increased risk of adverse effect. Like combining ACE inhibitor and ARB is not recommended. Beta blocker and diltiazem verapamil can have adverse cardiovascular effects. Combination of alpha adrenergic blockers and clonidine should also be avoided. We should also avoid beta blockers and clonidine. So when should we consider monotherapy in patients with stage 2 hypertension? There are some indications where we start with monotherapy. For example, if the patient has a history of allergy or intolerance, we may have to start with the single agent and then add other agents sequentially to find out exactly what is the source of the allergy. In patients with secondary hypertension or renovascular hypertension also, These patient needs more frequent titration of medications. So it is prudent to start with a single agent and titrate quickly. For patients at risk of orthostatic hypotension, monotherapy is preferred initially. For elderly and frail patient, also it is prudent to start monotherapy. So we've started Jerry on appropriate treatment, and for follow-up, we are going to call him after 2 to 4 weeks. We're going to monitor his electrolytes and creatinine and check adherence to medication and adherence to the lifestyle modification measures at each visit. If Jerry meets his treatment goal, then we can schedule the follow-up for every 3 to 6 months. If the target goal is not met, then intensification of treatment should be considered. Finally, we have our third patient. Let's call him Spike. So Spike comes to our clinic with severely elevated blood pressure. His blood pressure reading is 195 over 125 millimeters of mercury. So as per the AHA classification, Spike has severe hypertension. So for severe hypertension, we should immediately start assessment for evidence of end organ damage. And we should take a decision on whether to treat the patient as an inpatient or consider the patient for observation. This we will be discussing in a separate video. So I hope you enjoyed our videos. Please don't forget to like, subscribe, and hit the bell notification so you don't miss any of our videos.